Good morning. Can everybody hear us?
Oh, yes. I'm Dr. Ajit Desai, and with me is Dr. Karthikeyan, who will be taking you across with the discussion here on the panel. We have an elite panel here to discuss the cases. Yeah, please go ahead.
Okay. Good morning from New York. Myself, Dr. Annapurna Kini, Director of the Cath Lab. Dr. Savin Sharma was with you there. He should be joining us any minute shortly. Meanwhile, I have Manish Vinayak, who is our junior faculty, who is going to help me with this case. And then we have Jarmanjit Singh, who is our fellow, and our usual Cath Lab people who are with us here. So imaging will be Kiski Yakamura. You've seen him many times. Nurses are Will and Ashley, and technician is Asif and Hakim. So we are going to show you the slide. Can you, do you see the slides? Yes.
Yes, yes, yes.
Nothing to disclose from us. So this is a patient, 81-year-old male, who has history of hypertension, controlled, hyperlipidemia, controlled, CVA 2020 with mild residual. So SAQ of 55, saying that he does have symptoms with a BMI of 20. So these are the important cardiovascular labs that we always check on most of our patients. His hemoglobin A1C actually is controlled, is about 5.8 now. LDL, you see that on about 48, CRP 0.6 and creatinine of 0.8. So that is his risk factors. He presented with angina class 3 way back in December of 2024 and also had a high risk MPI showing ischemia in all three territories with preserved EF. So because of his old CVA, he has a limited mobility, but also very frail. You can see the medication that he has was initially was only on aspirin, and then we added clopidogrel, 2 anti-anginal medication, rosuvastatin to control his LDL, as well as estomib. So when he had his cath, December 2024, revealed severely calcified 3-vessel left main CAD with normal EF. Syntax was 42. STS was 4.2. We recommended cabbage because of 3-vessel and left main disease, but he had a heart team discussion because of his frailty and age. Cabbage was declined. At that time, he came back and then we did the right coronary artery intervention, and he was being managed medically. If you go to the OC criteria, you can see that he would be appropriate because non-diabetic and heart team discussion after left main. So after doing the RCA PCI, he was managed medically, but continues to have symptoms. So today he's here for left main, LAD, and circumflex PCI, and we'll tell you what would be the plan. This is where we are. This is just what the guideline says. The patient is a stable CAD, left main disease, surgical consultation obtained, and based on GDMT, which is on GDMT, still symptoms, then we are going to go with the PCI. So we can show the angiogram now. You had a lot of lecture by Dr. Dangus showing a majority of our apps. So this is, if EF is good, EDP was just normal. He has a little bit hypo in the inferior and apex, but overall is a normal LV. This is the right coronary artery that was intervened. So he does have a lot of distal disease, which we said we'll leave it alone even at that time. So this is a fluoroscopy cine showing us that there's a tram track calcium without even imaging in the LAD and left main. And this is where we are. There is left main disease, proximal LAD, moderate mid LAD, and there is a tortuosity. There is a moderate size diagonal, which is significantly diseased, D1. And in the circumflex, questionable, osteal disease, but OM1 is again small, but non-obstructive, but significant disease again in OM2. Not a lot of calcium in OM2. But this is where we are. So what we plan to do here will be that in this case, likely we will not image first, since we already has determined that it is severe calcium. We'll do you cannot do primary rota wiring. We wanted to do atherectomy with rotational atherectomy. The question is, should it be rotational atherectomy? Could it be orbital atherectomy also? If somebody says they want to do orbital atherectomy, it's okay. But with this tortuosity, we have to be very cautious with wire bias, even in orbital atherectomy. So then, once we will not do primary wiring with the rota wire, you have to take a workhorse wire, use a microcatheter and change to rota wire. At that time you can decide, but still plan is, I think we would go 1.25 bar for the LAD and then image, and if we need more calcium modification, we can consider a step bar or likely IVL at this time. Now we can ask the panel.
Can we have the LO caudal view, just to show what is the bifurcation here?
Screen south, please.
Move the screen. We are going to do that right now for you.
Yeah. And also, what is the tentative plan here? Are you planning for a two-stent strategy, or you're going in for a provisional stent?
I mean, that's something we can discuss. Two-stent strategy. Okay, go.
More or
I
less.
think it's a okay. Yeah, I don't think I want. Now, do we think that diagonal is a sizable vessel that we consider two stents there? No, it's not going. Okay.
Yeah. Yeah.
Yes.
So if we go back to our yeah, RAO,
Yeah.
right?
Yeah.
Good. So we'll do our wiring with the microcatheter and fielder wire. Then we will use the rota wire. So going back to the question that do we do single provisional stent of LAD diagonal, or do we do provisional stent of left main circumflex? What does the panel think?
Yes, I think that would be assessed after you do the IVUS, depending upon what is the plaque burden in the distal left vein, as well as in the LAD or the diagonal. You think so?
I mean, even we are not going to image the diagonal. Have a run through wire ready, right?
Run through ready.
So now, okay, this made the turn. So if that was not going to make the turn, then I was going to use the run through wire. This is a polymer jacketed, hydrophilic, able to move through all the tortuous calcific area easily. Now I'll get the microcatheter and then wire the rest. Now just see here. With this kind of tortuosity, I think we should just downgrade the burr size, though. And you see that the mid to distal lesion in the LAD, there is calcium and could be a bridge
just
also.
in case, do you have a...
Okay,
Dr.
so
Kinney, hi, I'm
yes.
Dr. Karthik. I'm a cardiologist from England. Now, fantastic case, and pretty much day-to-day type of a patient we come across in our practice nowadays. Just a quick couple of things. Yes, it is short tortuous, and wiring would have been a challenge, and to consider a larger burr for rotablation. I was just wondering, would you consider an intravenous, intravascular imaging first to decide whether you would indeed want to go ahead with rotablation first, or would you consider an alternate option for calcium debulking, number one?
Mm-hmm.
And number two, without meaning to distract you from this main lesion and the left main procedure, the first obtuse marginal seems to supply quite a large of a myocardial. So would you have considered treating that prior to fixing this lesion?
Yeah, very important point and a very interesting point. No, you went very high, mag. Decrease the mag. Yeah, so going back to your first question, would you do IVUS with this kind of a tortuosity on almost 95% lesion in that LAD? I am not sure IVUS catheter will make a turn. We could try it. No, why it
It's
became
spontaneously
super
happening.
magnified? Okay.
Absolutely.
Yeah, so that's one thing. That is why, and see the other rule of thumb that we do is that the microcatheter crossed, okay? And I was able to change it to rotawire. Then can we go with one fiber? Yes, we can go with one fiber. But I'm really worried the way the LED has just at the level of the septal, the dip that takes. Now, why 1-2 fiber may just do some kind of a path. And now since we have our other devices available, especially IVL, so if something needs to be done, we can do the IVL. Going back to your question again, that should we do rotational atherectomy itself, or why not we go with the IVL first? Do you want to try IVUS?
Yeah, yeah.
Okay, let's quickly try IVUS, but it will be on the rotawire. So, the body of the rotawire is not as good, but still we can quickly try. Could IVL be done? Not sure with the IVL, with our experience, could it made the turn in that area? We will
Agreed.
definitely need, and before doing IVL, you definitely need to image to understand the sizing. That's for sure. These are all the thought processes.
Okay,
So going back, that what is the thought process that IVL likely will not make a turn into this heavily calcified, significant diseased LAD. Okay, so that's one. Because even in disrupt CAD, we knew that 50% of the time they had to do PTCA even before getting the IVL down there. And if we are, since it is severe calcium, we do not want to get into that route. Closer. Yeah. So this is what we have predicted. You see that? Can you see anything? No, it's haven't even got into the.
Oh, we are not able to.
Yeah. No. See, this is what we predicted, and that's what is happening. So we have to quickly do the rota, and then now somebody may tell me you didn't use the workhorse wire. So then you are doing a workhorse wire, doing imaging, then you are going to change it to rota wire, too many steps.
So precisely you're using the 1.25 because of the curve, or you're not worried about going in with the 1.5 burr here?
Because of the curve. I'm worried the way from left main to LED at the septal level.
Signing of the
Can I let me go back, and this is IVUS. Look at that wire.
on
It's so biased.
clip.
This is just a cine.
Yeah.
So when you see something like this, you have to be very cautious
Yeah,
and downsize the bar. And that's what we are doing.
yeah. Off carpet.
Okay, good.
Off carpet. Yeah.
Yes. So we have 150. This is a Rota Pro. So it comes with a fixed 150 RPM. I'm going forward. Manish is just holding the wire. Is there any other points that panel want to talk, discuss? So now I'll bring it up to the left main.
Any questions from the panel, please? Anand?
We'll do our 3 steps. Move this knob, Y connector backward forward on the dyna. Okay, good. So that's how we know that the burr has been nicely prepped. Okay.
A patient like this, in a clinical scenario like this, I think the best way is upfront we should decide on a single stent strategy. Patient is 81 years old, frail, just needs relief of angina. So left main to LAD one stent should do.
Yeah.
But I'm a little bit doubtful that the OM may be the cause for the angina. Yeah.
Now look at the way the burr is facing here. You see that?
Yeah, the angle.
Yes.
I think because the right has been already treated and OM is
Now
still a
can you see
significant-
how we are navigating the burr?
Yeah.
Yes. So if you had a 1.5 burr at that level, you know, despite a lot of experience that we have here, we will be very cautious. That was the main reason to downgrade. So this is our first one. You see that? How the 125 burr is just slow pecking
Dr.
motion.
Kinney,
Yes.
Dr. Kinney, when you're doing this rotation, I'm Dr. Vijay from New Delhi, and a good friend of Manish. So I had just a point to tell the audience that when you are doing this rota burr, your distal tip of this rota wire, the shape that it has taken looks to be safe, but always there's a risk of the wire breaking like this. So I think we need to be careful when you are using a rota burr and the wire is bent like this. So care for the distal position of the distal wire has to be very importantly handled.
So you'll see that if Dr. Sharma is here, he would, in the back, he'll be moving the wire many times, exactly for the point, saying that if the wire is, you know, just at one point, there's a risk that it could break.
Yeah,
That's a good point you made. Yeah, good. So now immediately I've done, you see the hemodynamics are good. So let us take a quick picture and then you see the wire bias and how the rota has made a cut. Okay, now let's go with the run through wire. Remove this and then we can try the clip.
Clip is. Yeah. Yeah.
So now we will go with the workhorse wire. I agree with your point that, you know, that you want to take care of the circle. Let us take care of the LED first, and then we can, if you think, yes, that's an angina, and that is what his symptom is, that we have to just take care of OM2, that's okay with me also. So we are going to wire with a workhorse wire. Now there's a lot of wire bias and dissection, okay?
Yeah.
We have to be cautious when we wire. And
So
after
what's
this,
the
we will IVUS. Workhorse wire is run through for us.
So in calcified lesions, you will still prefer a run through or better or a wire like All-Star or Grand Slam would be, because you have a tortuous artery and then you have to take a stent across the calcified segment, and you may need high pressure balloons also later on to optimize your result. So, I mean, beyond workhorse wire, I think a wire with a better strength is also not a bad proposal.
Yeah, but Grand Slam you have to see is a very, very old
Grand Slam
generation.
or All-Star wire. All-Star
Yeah.
wire. You see in this run through is not going to support your guide sometimes. The guide might back up, or the or when you have to
Trio.
take a say a long stent, or you have to use a high pressure balloon, then you'll need a different wire than the run through wire.
I mean, ever since run through was introduced, we do not carry Grand Slam anymore. We used to have Grand Slam as well as mailband. We used to have another wire called mailband, which was a heavy body. So yes, that's true that if you need a lot of support, you'll need. But now, with the introduction of run through as well as introduction of Guardliner and Godzilla, there's no need, because those wires are very old generation. The one-to-one torque is not the best. They also cause a lot of wire bias.
No, but when you need, see, you're dealing a tram track calcification, you will need an IVL, and after IVL, you may still need a high pressure, a super high pressure balloon. Then this wire is not going. Then you'll have to take a stiffer wire on which the high pressure balloon will be used to dilate. That's what it is said. What is your practice when you use your OPN balloon, suppose? Then you have to use an All-Star wire or a Grand Slam kind of wire. It's not going to work on it's going to stick to the run-through wire.
Okay, during all our live cases, we have shown our workhorse wire is the run-through wire. Yes.
We have started with a heavy wire, a heavily calcified lesion. So we should be foreseeing that these problems can arise. We may not be ending up even after an IVL with the best result. So the wire has to be, I think it has to be a heavy wire right from the beginning. Than a common, suppose somebody uses a cyan blue or BMW as a work through, workhorse wire. And if you use high pressure balloons, you are going to be in trouble.
So we see that the IVUS catheter did not go across on the conventional wire which you have used.
Yes,
So are you planning to dilate it now?
we are going to dilate it. I wanted to see what Rota has done. Go up. So this is a 3.
Yeah.
We are now going with the visual. Okay. So this is
Yeah.
where the most of the area is, and then we may be able to do IVUS now. Okay, go.
That
Okay,
is a
this is the left
beautiful
main. We are
expansion.
doing the left main now. Yes. So good expansion, which is trying to tell us maybe we don't even need IVL, but let us see down. Now I'm going to
So
that mid to distal LED lesion.
Dr. Kenny, you pass
Yes.
the wire, the side of the rota wire. The plan is that if you want to do a rota with a 1.5, is that the plan in case it is needed?
In case it is needed, exactly. That is the plan. But now you see it is open. It has opened very well, so I don't think we need that. That's one. Good.
Other
Also,
than
keeping the rotor wire next to it helps it to be like a cutting balloon effect
Yeah.
as well.
One cutting balloon, body wire.
So
Down.
I'm a big fan of Grand Slam. So especially when you have a microcatheter down, you don't need a torque. You can just take the Grand Slam down. There are times when we had to put two of Grand Slam wires. Yeah, yeah. Exactly.
Jumping like that. See, Dr. Kini, your guiding is jumping and it can cause a left main dissection. If this wire would support, then the guide would be more stable. It's just going to and fro.
But it is outside the left main right now. So let's pull this back. And now we go back in. If it does not go, we'll take a smaller balloon. Right? We'll take a
0.5.
I know we take the point, use Grand Slam and all this, but I'm telling you again, what is our practice and what we have done and all the live cases that we've been showing, that run through is our workhorse wire. If we need something, we will go with the Godzilla or guideliner if we need to deliver. Because there is a various ways of doing the cases. Okay, now give me the IVUS. Let's see if the IVUS can go now.
Yep.
What do you want to do there? 3 or 12, right?
Yeah.
Get us a 3 or 12 balloon. Yeah, compliant. Wow. Still not making a
Proximal
turn.
lesion, yeah.
Not going.
Yeah.
Now, can you see anything? That's left main?
Yeah, left main.
Yes.
It's not clear. Yeah.
Okay, upside the bar.
The proximal part of the left main.
Okay.
Okay, stop it.
No, not proximal. Maybe distal. You think it's proximal?
Sorry. Yeah, proximal.
Proximal,
Just a
yeah.
proximal. Even we didn't see there much calcium.
Are you planning to dilate the mid segment with a 2.5?
We are going to go 3 or 12. But before that, we are thinking that this left main, I think we've not done anything for the left main. That do we just see here, right? Take a
Yeah.
picture here. Since IVUS is not even making a turn. Go. Oh, yeah. We're going to take a better picture of the left main.
Yeah. Yes.
I think it looks,
Doesn't look too bad actually,
Yeah.
Dr.
Yeah.
Kinney.
I know it does not look too bad, but things are not going. So what we could do, let's take care of the LED first. And since we had also thinking that we have to take care of the OM2, we can take care of the OM2 and then stent across in the left main.
Yeah.
But if you see the other, all the other branches, right? This is what we are doing. So look at all the branches. I think we got to leave the diagonals alone. What do you guys think? There's
Agreed.
a OM.
Yeah. So multiple branches taking care of the LAD and OM.
So now we are going with the 3012 balloon. Now, even though, okay, let's go to the cranial picture. We did go with the rota once to that second lesion. Okay, go up here.
14, 16.
Okay, down. I think you have to put a 3-5, right? Or a 3
Basically
to 5.
3,
3 to
3 or 3 to 5.
See,
To
this
our
is where,
other friend,
yes. What's the question?
so any
Oh,
specific
really?
stent choice you have for with so much of side branches where just want that they should not get occluded?
I mean,
Choice of
yeah, I mean, choice of
and
stent.
in a tortuous anatomy. What was your
wait, wait.
stent? I missed out.
No, I did not mention. I said stent choice. I know the data are saying thin stud stent probably better to
Especially
avoid.
the left main.
Yeah.
Ostial left.
You
Cross.
want ostial left main?
Yeah,
No.
no. Crossing
No,
was
no.
difficult.
Let's, yeah, go up here. We carry two here. One is Zion's, other one is
Synergy.
Synergy. Based on our experience, I think the side branch occlusion depends upon the anatomy of the branch and the main vessel rather than the type of stent itself.
Now, are you planning to put in the IVUS catheter? Now they are.
Oh, you want to? Okay,
Yeah.
we'll try again. I mean,
Because I'm
I
concerned.
mean,
that
we really have gone very high pressure
bleeding.
in the left main now. Hopefully, let's see. What's your concern?
There's possibility of a calcium nodule at the bifurcation of the left main from whatever little IVUS projection you did in the left main.
Okay. Other thing is that do we go with the 3 to 5? 3-5 may be still large. Whatever IVUS you got, what is the left main Kiski? Little IVUS we got. Okay, so we
Yeah.
needed to
Yes.
really expand that left main there, yeah.
Okay, I check the image.
Okay,
Okay, start pullback. It's coming. It's mid LAD. Here's not much plaque. Here's some myocardial breach.
yes.
Now the lesion start. Here's not much calcium, 1 degree. Yeah, I see some nodule here.
Yep.
Yeah. Come to
But
the
that's
left
in the
main.
LAD, right?
Yeah, it's
Yes.
aorta. Yeah, we
Shows
started.
the distal left main, and when you said nodule, that's I think proximal LAD, right?
So I'll show you. So now I come to the left main. No, aorta. I go distal. This is a proximal left main.
Yeah, this is
And
the nodule.
This is a distal left main. Yeah, here is like slight nodule protruding inside.
Yes.
Looks like surface is shaped by the 1 to 5 bar. Yeah, but it's true. Some calcium nodule at the distal left main.
Yeah.
And now come to the proximal LAD. Yeah, here's also looks like nodule here.
But
Like,
what
Yes.
we have done enough calcium modification, right? Or
I
are
think
you?
so.
Do
I
we
think
suggest
so,
that we should
because
go IVL?
Other half is not much calcium. The shape, surface of the nodule is shaped. Yeah, here's also like eccentric calcium, but not like 270.
I think we can, based on the imaging, we can just stent it. What do you think?
I think so. Even the angio showed a good balloon expansion, right?
Yes.
But now the lesion is very long.
You'll need 2 stents.
Yeah. The distal reference is 1 second.
Go back to the distal left main and ostial LAD just to be very clear that we are
Sure.
going to now, do we need more high pressure or cutting balloon, PTCA, IVL, three
So this is
choices.
the level of the distal left main.
Okay. Yeah, that's
you see
okay.
that like 6 to the 9 o'clock has a nodule and a surface is shaved.
Yes.
But other part is not that much plaque and not much calcium. I think you did a good job.
We are okay to stent.
Yep.
So this is the point we are trying to make, that despite being nodule, what we also published and presented, recently our publication came out, is that you can have a nodule, but what is important is what is the amount of calcium that is in the vessel surrounding the nodule. So there is, like Kiski just mentioned, it's not a lot of calcium around. But if there's a lot of calcium around, that's the time you need to think that to take care of the calcium plate around that, you may have to do either a bigger burr or you got to go with the IVL. I think based on what we see so far, he's saying the nodule has been shaved. We can just go ahead. You want to do high pressure left main?
High pressure left main, and we have to fix OM first. No?
Yeah, we'll do that. No, we'll take care of the
Mid
LAD first,
Mid
and
LED.
then we'll take care of the OM and then stent across.
Yeah.
Is that a okay plan?
Yeah, absolutely, yeah.
That sounds perfect.
And what is the distal landing zone? I mean, what, distal landing area?
After the bridge, you see
Yeah.
that mid to distal, that there is
So
a bridge.
Three
Yeah.
OS.
Now see
So we got to be very cautious
This is a bridge, like a bridge. So we don't want to cover that.
3.2. We were thinking 3.25 Zions. Give us a 3.25 38, and then proximally we will do a 3.5, and in between we will do the OM. But Manish says that let's go with a cutting balloon. Let's get a cutting balloon 3.5 to the left main, ostial left main, and then we will take care of the LAD stent.
Yeah,
Yes.
Dr. Kiri, that's a great idea for the cutting balloon, but having had two wires, the rota wire and your wire, workhorse wire, that would have worked as a cutting balloon anyway. I was just wondering if you would have considered a long NC balloon at the ostium of the LAD for two reasons. One is you are achieving a cutting effect with that, number one. And number two, by getting a longer balloon, it also is a test of whether you can deliver your 38 millimeter stent in the mid vessel. That might sort of help you determine that. Just wondering.
Yeah, very interesting point, excellent point. The reason is, despite us having, remember these have blade between 3 to 4 depending on the size. So we have 3, 5, it will have 4 blades. So why we say the buddy wire works as a cutting balloon, it's a poor man's cutting balloon. It's not a true cutting balloon where you really have the blades. Yeah. So that is why you need to do the right thing. So we'll go. But your point of taking a long one and checking whether the stent will go is well taken. We hope we are doing all this work to this vessel. It should allow the stent to go. So this is distal left main. Manish wants that. Go, Manish.
Yeah, well expanded.
Okay, down. So it is expanded. And IVUS also showed us that to us. So, but I will go into the prox LED, but go 12 to the. Now with this newer generation, we can go 18, 20 atmospheres here, but we are not going that high, down.
Yeah.
Give us the stent. So we'll do the LED stent and then we'll take care of the circ. So once we deliver the LED stent, we will remove the rotor wire.
38.
38? So Dr.
Or you want to go smaller?
33.
33.
Balloon. When you're using the cutting balloon, would you like to do it twice by rotating the catheter? Say maybe about 2.
Yes, 100% agree that when you are doing that, but here, if you see your first inflation itself, it did a good job. Okay, I didn't see that. It opened up very well, so you don't need it. So what you do is take the cutting balloon back into the guide, then you rotate little bit, essentially trying to change the way the blades are facing, and then go back in.
Yeah.
Very important point. But since it fully expanded, we didn't want to do that step again.
Go cranial.
Yeah, go cranial. Now with the help of imaging, we exactly know, I think, when we needed to go IVL or that we didn't need to go IVL. Now going back to the original question that, remember we were discussing, should rotational atherectomy be done or could we have tried OPN balloon or could we have done the, so this is a 33. Could we have done IVL? The way we have shown you multiple times, even IVUS was not going and we were having issues. I mean, those devices probably would not have made it to this level. You guys agree?
Absolutely.
Absolutely.
Okay, good.
Looks good.
Yeah, go up. So this is a 32533 and we are going at 14 atmospheres. Down. Good expansion. Go up again. He's having a little pain. Yes, don't go
Stretch
too
it,
high. Yeah, good. Whenever you see a bridge, you got to be highly cautious. So now we come back and we take care of the OM2.
Filter.
Give me the filter wire. And I think when we are doing OM2, can we just remain focal rather than come up to the left main? Because if you're coming to the left main image and all that, now we are talking about bifurcation, mini crush, left main.
I couldn't agree more with you on that, Dr. Kinney.
Yeah, but I think you need to come back at least up to the circumflex because just before the origin of OM2, there is a significant lesion in the circumflex. May not be up to left main.
Okay, ready?
Yeah, guide.
Yeah. Okay, good, good. Okay, so you see that the distal LAD looks good. We are trying to, okay, we come up. So we will go below, the goal should be below that small OM. Okay, what's the balloon you want? 2.5, right?
2.5, yeah.
Get a 2.5, 15.
Even the
So
circ looks calcified, you know. The delivery will give me vision.
Okay, let us see. Manish thinks prox-circ is calcified, which is moderate calcium, that we may have issues at that level. Give us a compliant balloon.
2.5.
Some dye. Show some dye. Okay. The thing is that, yeah, calcified lesion in the left main may not allow us to go into this area now. Yeah. 10 minutes for the case? Yeah. Okay. You're saying we only have 10 minutes for the case? Okay, we'll stand across. Let's give her the balloon. Hopefully things will go easy. And case key proximal to left main, right?
Yep.
We'll do a, right? 3.5.
Yeah, you
And
can.
I'm not planning to come up to the ostium of the left
No
main.
need.
I think that should be okay.
So initial total length was 50, so you put 33, so maybe 20 or 20 plus.
Another 33? No.
20 something.
2.523 should be okay here. What do you think? Okay. So, but this is a compliant balloon. Go up. Okay.
Despite the
Down.
calcium and the toxicity, it has gone down nicely.
Yes.
No.
Okay, go up here. This is where the issue is. Okay, down. This is a 12 or 15?
This is 12.
12, right? Go up here.
Yeah.
23 should be okay. No, not make it
I
down.
think
Down.
we may have to
Did
go
it
more
not go
distal
down?
low.
Yeah.
Yeah.
Okay, go up here. Go up. Okay, down.
Yeah.
Okay.
Go.
Okay, take a picture. Okay. 23, right?
Yeah.
Okay, get us a 2.5. Distal is not
2.5.
2.5.
This is up
Yeah.
to, you know.
2523. So
23
we are
or
going to
28?
take,
28, no?
no, it's not going to make a turn.
Okay.
He wants a longer stent, but I'm worried will not make a turn.
Sure.
No, but you need to cover the segment just before the origin of OM2, right? Do you think a 23 would be enough? I mean, it looks like it needs more than 23.
I think we'll be okay. We'll go just below the OM1 to give quickly. And then get us a 33.
Yep.
For the
Go ahead.
left main, proximal LAD to left main, we'll do a 33.
Yeah, go ahead, sir.
Can you tell about the small circumflex model you already showed us slow flow? No wire there?
I'm not sure if you can hear.
No, I could not hear
Dr.
the question.
Dr. Kiri, one of the audience has a question about the slow flow in the the second obtuse marginal, and whether you are concerned about that.
Not, you mean the distal circ, small distal circ, right?
That is, yes.
Yeah. I mean, we're not concerned because we have actually caused so many issues already. OM1 has a little disease, D1. We didn't dilate here, right? Okay. We were trying to avoid that area. Get the balloon again. Get us a 2.512 high pressure balloon. So we need to dilate that area now. Where we thought that there is calcium in the proximal circ.
Agree.
What time are we stopping the transmission?
There is no limitation on time.
Okay,
that's
fine.
I think you can finish it. We'll wait for that.
Okay. So we did not come to the proximal circ closer to the ostium, thinking that we do not want to touch that area, right? But, okay, go up. Now we are going with a high pressure 2.5 and hopefully creating a,
1460.
okay, down. Go up here. Down. Yeah, it's okay.
Yeah. Yeah, so the question was, would IVUS help to assess the proximal part of circumflex? Because there is some difficulty in taking the stent.
Okay, now I'll try to stent it. If try to go with the stent, if it does not, then we go with the IVUS. We have an excellent point. It could be that distal left main, despite us, dilating the distal left main, cutting, and sometimes what happens is that we have disrupted that area and then we have some issues. That's one. Number two, proximal circ, probably there was moderate disease. We didn't want to touch that area. We thought, let us do the OM without doing anything in the proximal circ, but that's not going to happen because I think there's calcium also at that level. So delivery of the stent is becoming an issue. This is just based on the fluoroscopy. Now let us see if the stent does not go this time, then definitely we'll do the IVUS.
So here sometimes you can use your guide extension or guide liner to deliver the distal stent. If you have a moderate calcium and you don't want to touch it, then you can just pass on the guide liner and then deliver the stent distally rather than disrupting the proximal and making it more complex.
Understood. I think maybe we may have to do that. It also could be the way the circumflex, the angle with some calcium,
Yeah.
it is hitting the tip of the calcium there. Yeah.
Yeah.
So the way it's
not
what you told us, go with the Godzilla. That's number one. Other one
Yeah.
is you can do another wire so that it deflects
Yes.
away from that. So these are the two
Yeah,
options. But let us go with the Godzilla only because guideline. Godzilla. Yeah,
Yeah.
Godzilla, because we know we will be able to deliver it.
The point could be
Yeah.
that the Guidezilla, because of the second wire, we won't be able to take it all the way in. It will stop.
No,
at the
we will go with
bifurcation.
one wire.
With the one wire, then we have to remove the LED wire.
You're saying that?
Yeah, so yeah,
One
with
of
the
the-
guide like
So there's a,
No, you can probably a guide plus 5.5 would go, but a 6 French guidezilla will with some resistance in the guide.
6 will go. It's a 6 catheter, no?
No, I think
Yeah,
the 7
let's
French
try.
guide.
Because we can't go on, we cannot go on 2 wires. We got to exclude the LED wire right now. You understand? Otherwise, Godzilla cannot go down. So give me the balloon also.
Exclude, but
Balloon
we were discussing about the resistance in the guide. When you
Yeah,
have a
yeah,
wire
yeah. No,
outside-
that's what Manish is telling me also, that we may have issues. We'll try.
2.5 compliant.
Otherwise, we have to do. Do you want to try double wire then?
Yeah, sometimes you take both the wires to the Godzilla and then pull the one and then deliver it to the circumflex, the Godzilla.
But
No,
since we
you
have so
understand, but
protection,
LED has so much disruption. I don't think we should remove the wire.
it meant
Yeah, no question. Removing that will be disastrous. It will be better to fix the left main to LED rather than removing the wire there.
considering that we were not planning to treat the OM upfront, and we've all discussed about this, would anybody consider
So
just a
sometimes,
drug-coated balloon treatment? to be
sometimes it is
separate?
always that is. Sometimes it is always that is why wiser to do the OM first and then do the LED. So you could have fixed the LED OM first and then did all the rest of the task on the LED left main.
Considering that where we are now, would you consider a drug-coated balloon treatment? I mean,
With
you got
that kind
immediate-
of a dissection, right? I don't think a drug-coated balloon could be done.
No, so the
He's
Agree.
talking about the OM, I think.
Yeah, yeah, OM, I
Yeah,
understand OM. Now, going back to the point that should we have done the circ. So you have the main vessel, which is left main to LED, and that's where you should focus rather than, I mean,
No, so we were planning for the OM, the distal lesion. So the distal lesion could have been treated. We'd never planned right from the beginning to bring our stent proximal to the ostium of the circ. So treating the distal circ would have been easier and more straight cut using all these Godzilla support wires or whatever, and then do the left main to LED.
But again, we would have ended up in a similar situation, right?
Beg your pardon?
Without a prepared left main, we would have ended up in a similar situation.
So left main, you have presumed or you have seen by the imaging that you are not coming to the left main, right? The whole left.
no,
main.
no, imaging happened now. When we started the case, there was no, I was getting into the left main. You have the left main to LED sitting in front of you, and then we are going behind the circ. That would not be ideal.
Anyway, some maybe a stent, some other stents, more flexible ones can be also tried.
Okay,
Xyans
let us
is-
see how this behaves. You have Osiro,
Yeah, sometimes we have.
You can have
done
an
with
anchor
five.
in the LED
zero-
stent.
but I think we
Onyx.
don't carry.
You can put an anchor in the LED stent also,
Yes.
because the guide is backing out so much.
Yeah, we could do that. Let's see if this does not go. Okay, go.
Because of the second wire. It will,
Yeah, it is.
it
No,
will
no, no,
create-
we are outside. No, should not be. Okay, go down. I think it's not. Okay, go up here. Second wire is not obstructing us. That's there. Okay, down. Go up here. Go up here. Go. Okay, good. Deflate.
deflect.
Question is, would it go now?
Yeah, we can try skank now. Yeah.
Yeah, get the
well,
stent
so
now.
far so good, Dr. Kinney. Yeah. So you have a 7 French system there, obviously.
Yes.
Yes.
Get the stent. You have a Osiros, smaller length. You wanted
but this-
28. Remember, even I was
Yeah.
questioning 28. Yes.
The guidezilla that you put is actually sitting in the exact point where the stent also was having resistance, right?
Yeah. So, no,
So-
I think the only way is a double wire probably will help us, get us a run through. If this does not go, we'll try the double wire.
You shall go.
Oh, this is calcium not allowing anything to go.
Further down.
So this is the nodule that was there just proximal to the OM2 origin. I think that also needs to be dilated more.
No, no, on the IVUS we saw it was done well and we did the cutting balloon. This is that despite us. Okay, I think we got to change the strategy here.
Probably if
We'll
you
go with
engage the guide a little
get us
deeper.
a small. Get us a 15 millimeter stent quickly. 2515. Quick, quick, quick.
The guidezilla across the left main is causing some hypotension, I think.
Yes, that's why you have to be very, very fast here. If this does not go, we will do double wire or
Or which?
let us see a shorter stent will make a 10.
Yeah.
Okay, good. Good. Okay. So we have a shorter stent, but that's okay. We have at least something there. We'll do a bare metal stent strategy. PTCA before, PTCA distal, some die. Oh,
It's occlusive. Yeah.
it's okay. It's okay.
Maybe
Okay.
decline. No?
Hold on.
Yeah.
Now we have to decide. We cannot pull back.
Yeah, because we put this.
Yeah, the distally we need to cover.
Yeah.
Proximally we can leave it with the. Okay, good. Go up. You have the left the LED stand. 33, 3533, right?
Yep, that bit as well.
Okay, go up again. Now here, go up. So this is not ideal in the sense we have not covered everything, but still the tightest area would be covered with the stent now.
Agree. But considering that DCBs are just in the US now, is there an option of considering a DCB from the proximal end of the stent back to the left main? Just to treat that bit with at least a drug-coated balloon rather than a stent, and then you can stent back from left main to LED back to left main.
I mean, it's a good suggestion, but I think we are very cautious with who should be getting a DCB here because it's still very expensive. Each DCB is $5,500.
Wow, okay.
Yeah, come. I call it's an engagement ring, the price of an engagement ring. Go. I think it looks very good. I'm going to remove that wire and let's focus on the LED now. Because the wire was already crooked. So, what do you think, 33? You want to take a cranial picture?
Yeah.
We'll take a cranial picture because we never did a cranial picture after we did the LED stenting. Everybody's okay with the way the circumflex is now?
Absolutely.
Yeah, good. Okay, get us the 3.5, right?
Yeah, 3.5.
Yeah, see how you can.
What did you say we needed? 28?
28 is enough.
28.
Yeah.
3.5, 28. That's what I was looking at. It looks 28, not 33. 3.5, 28. So we're going to do 3.5, 28, and then we will take care of the left main. So left main looked 3.5, 4.0.
Dr. Kinney, one question here.
Yes.
I'm seeing the slow flow in the diagonal, that big diagonal which is there. So will you like to keep it open wire strategy? Just put a wire?
No. Right now, finish your left main
check my
LED and
please?
come out. Yeah. Because you don't see any EKG changes. We already have issues with left main LED. We tried to say, okay, let's do OM. And we faced a lot of issues at OM. So I think at this time, it's telling us that don't try to go behind side branches. Yeah, just focus on the main vessel right now. Let's finish
not
the main
working.
vessel, stabilize.
Narrow again.
It's already coming to an hour. Patient is becoming restless. All these things should be taken into account. So now we are going with the 3.5 LED to left main. Now, could you have left the circumflex wire? Yes, but the way the wire was
Yeah, good.
turned, huh? We didn't want. What you guys are doing? Some
Are we overlapping?
Okay, good. Connect,
Okay.
connect. Get the IVUS. Kiski, was it 4-0? 3-5 only.
Left main
main.
is follow. Left main side is follow.
Okay, now hold on. Now let's go to this view. We want to take a cine?
Yeah.
So we are nicely covered in the distal part, okay? Now we want to make sure we are not truly hitting the ostium because we knew ostium was okay. We want to make sure the distal left main is covered. Okay, ready?
Yeah.
Oh, it's coming up to the ostium. We're going in a little bit, okay?
Yep.
Okay, some die.
Yeah, this
Good?
looks good.
Yeah.
We are covering. Yeah.
Good, go up. I'm going to pull the guide back as they're going up. Good. Down. Get us a 408 pot balloon. And then we will do the final IVUS. Now, when this is done, we are going to give some more vasodilators and look for all the slow flow in the branches. Ready for the final IVUS, right?
Yeah.
Yep.
Now, ideally, I would have been more aggressive to get the Godzilla down in the circumflex. We did try, you know, we inflated the balloon in the proximal circ. When it deflates, I was trying to go in. The question is that the wire in the left main, was it preventing from the Godzilla going forward? I doubt it. But the lesion and the nodule of the distal left main was well taken care by our cutting balloon. We have shown that 3-5 cutter opened very well. So we're just going to do the proximal optimization of the left main here. 4018. Go. Yes. No, you're okay. What is he saying? Okay, Dr. Sharma has landed. He's saying he's going to be here shortly to finish the case. Good, go. So we have to continue till he comes. Keep going.
Normally, we would take an injection to see where the
Yes,
circumflex organ
yes, we will.
IVUS, yeah.
Okay, go.
Angiographically, we're seeing the calcium
Yes,
over there.
yeah.
Yeah.
So Manish is saying angiographically he sees the calcium. So, but the point is well taken. No, that may be because we did not engage properly. So if you engage properly, okay, now you take a picture. We have to give some vasodilators, okay, and done. Ready? Now there's slow flow in many vessels, but I think we have to consider vasodilators now, right? Maybe the D1 also is gone. You're seeing the little bit STs now. Now you see a little bit STs. From the D1.
D1
Yeah.
is gone. Yeah.
D1 is gone.
Yeah.
It was looking that it would.
Yes,
threatened.
we knew that. And also look at that OM1 small vessel, right? There's a slow flow there also. Do you want to post there? Right?
Proximal, yeah.
You have 3.5? No, we don't
No,
have. No, you have
no.
3.0, right?
3.0, yeah.
We are going to do a post dilation there now, the proximal LED.
Yep.
Yeah, because
Now-
that's looking under.
Yeah. Going back to the LED.
Although it's eccentric. In one of the views, it's looking big. The IVUS may tell the area. You can.
Now, how
this
many
situation-
people will tell that go behind the diag? Or people will say, just manage on medicines?
I think first, as you said, give some intracoronary cocktail. And
Yeah,
that
that's
should
what we are
improve-
doing now. We are going intracoronary cocktail, which is nitro.
If it improves the circulation, then I
3,550.
think we don't need to chase anything.
No, we are talking diagonal, D1.
Yeah, so D1 also the flow might come. Sometimes it is not totally occluded, just the slow flow impairs it. And if you have given
Right.
enough,
I think
and
with such a
it might
calcified
again
proximal LAD and left main, I
No,
think we
knife
should
right.
not well at all.
yeah, we should not chase that.
Probably we could have kept a wire.
Yeah,
That could have saved the.
I mean, after preparing,
Yeah.
sometimes keeping the wire helps.
Keeping the wire for what? The circumflex?
No, I was saying that when you have already prepared and when you were going for the left main to LAD, and we were anticipating that the big diagonal might occlude. So sometimes I would have preferred to keep a wire at least by the and then stent it and then pull it out. Because sometimes these single large diagonals, they can become catastrophic. They start causing severe chest pain for the next few hours, hypotension, and then we just regret. That's what I think I've learned from the best experts.
Especially when the diagonal completely disappears.
Yeah.
You can't find it.
And then they will have huge ST changes,
Okay, ready?
enzymes going up.
Okay, good.
Just like
No, I think the enzyme changes are because of the circumflex. Yeah, the EKG changes are because of the circumflex.
The diagonal is.
I mean, that's the same. Diagonal has come back, no?
no.
So,
No,
it hasn't come back.
Okay, take a picture. Let's see me how to wire the circ.
Go ahead.
That's that the PTC, right?
Yeah.
The proximal edge has an issue of the circumflex.
Yeah, because and that's probably there is a dissection which is causing.
Yes, we could not get the stent there. Yeah,
filter.
get us a filter wire.
Put a small stent there.
Yeah, let's see if we will wire it. Yeah.
Yeah. That distal circ is flowing well. That proximal edge is having something. A small 8 millimeters might work.
No, we remember we wanted 23, but then things were not going. We changed to 15 and we got something.
Yeah. But here you can enter now. This is the wire.
We have a 2 or 12 balloon, and then we will try to get something there. Even a prolonged balloon inflation may, get rid of that flap. No, 2 or new 2 or 12.
No, 2.
So what wire is this?
Fielder. Don't give too much. What are you saying?
Reshape maybe.
Get us a whisper then, right?
Try a run through. Run through might go.
No, this kind of, because it's calcified, and here we should either need a polymer jacketed wire, fielder or whisper.
But run through also is fine, I think. Polymer jacketed.
There is
calcium.
significant brady.
Yeah, we give intracoronary vasocalicals.
Okay. There's no hypotension at least.
This long case, what is the ACT and what do you want to do with that?
There's a question about the ACT, Dr. Kinney. Has it been monitored?
310.
So any other view you would like to change to wire this circumflex? Because maybe
caudal
there
will
is,
be a better.
yeah, caudal view may you can go.
Okay,
And
some
if
dye
you
there.
have done a pot, then I'm sure the cell must have opened and it should cross, but let's see.
I think the takeoff angle of circumflex is not one of the best of.
Yeah, but so
It's
so
kind of a
LA
very
pot
funny
view
takeoff
and
angle.
then a little more curve
Yeah,
to
yeah,
the wire.
nice.
Yeah. Here it has gone.
This is a 2012 balloon. Okay, now we may need a 3 anchoring for the LED.
Yeah,
2012
we have
will not
3
go.
as well as 3.5.
3.5.
Yeah, we have.
So I may need to anchor in the LED to get the 2012 balloon in the
So
circumflex.
first 3.5.
Get us the 3.5 balloon.
Yeah.
So you predict that because there's so much difficulty in wiring, balloon may not go. And there's no way we are going to that. Teaching is that if the wire does not go into the side branch after the main vessel stenting, that you change the cell to come back and remove it. We're already struggling so much. We got through one cell, I call it the optimal cell. And now the way to get into the side branch is anchor. So you leave the balloon in the LED, it'll be ready. And this is a 2012 balloon in the circ, will go there.
A compliant balloon.
Compliant.
Huh? Yeah, that is from the circ. Could be diag also. Okay, go up of the LED. Okay, went.
Oh, yeah.
Okay, we were so prepared, it went. Go up. Get us that 2.5 balloon.
Okay.
Okay, down. You want to put a 2.0 stent? I mean, 8mm stent.
We cover from, do
Go
a
up here.
tap from, no?
I
Just
don't.
a
I
small
don't want to do. He's saying do a tap. I don't want to do a tap in a 81-year-old guy. Yeah, we'll
No,
just do a
not
short
needed.
stent. Yeah, we'll do a
Yeah,
short
yeah,
stent
sure.
there to cover the circumflex. Go up here. And I think diag, you need to forget about it for now. Down. I mean,
Maybe a
What
12
is
or
the short
15
stent
millimeter.
strategy? I didn't understand because
go take a picture.
idea is to cover from left main, right?
No, she's covering just the short proximal edge of the circumflex where there's a suspected
Skin
dissection.
circ, no? No?
How do we know?
I mean, this is angiographic now, interpretation, everything.
Okay, get the IVUS catheter.
I would definitely put it from the left main.
Hmm?
I would
This is-
definitely make it a button.
Yeah,
Huh?
I
Come
mean,
up
you
to
can,
the left main.
Yeah,
I think so, Dr.
Yeah.
Kinney.
Okay.
Since you have a stent there,
Okay.
tap would be a
Fine. So
Well,
now
we-
I will take, I think 12, no, you probably need like a
12 or-
14. I have to go 15,
Yeah.
right?
yeah,
12 is short. Okay, get us a 2.515. I mean, I would like to, if you guys want to IVUS, but I think even I have a deadline. I have to be out shortly. Okay, good. Get us a 2.515. Once this is done, we'll try wiring diagonal for a short while. Okay. Quick, quick, quick. So we will do the tap. Okay. Since everybody wants it, Manish wants it.
Thank you. Thank you.
You got to listen to your junior attending and fellows sometimes
Agree.
because they are learning from us and sometimes they give you.
Manish is making it more safe.
Hi, Dr. Vijay. Nice to hear you after a long time.
Yeah,
He's doing great. Manish is doing great. He has been next to me for 3 years. Yeah. Now,
Yeah, he has always been a very great guy.
yeah, very quiet.
Yes, I always
But skill-
liked him when he was in our hospital.
Anchor.
Okay, anchor now. Because the only question is we did a shortcut, and the shortcut is we opened the cell with 2.0. Ideally, you need to open the cell with 2.5. Now, will it go? No, don't do that because next you will have is a stripping of the stent. Get us a 2.5. We may have the same problem. 2.5 high pressure balloon, 2.75 high pressure balloon. 12 high pressure. Now we don't need to worry. There's a stent in the left main, the stent in the OM. So let's go 2.75. Really open up the cell, and let's see if this stent goes. And I think after that, EKG is better.
As long as the blood pressure is better, we don't worry for the EKG.
Okay, go up. No, EKG also has to be, go up, go up. 18. Okay, down. So we are opening that cell, 275, 18 to 20 atmosphere. So that stent will make a turn. Go up again, 20.
Yeah,
See
there
that
is- yeah,
ostium?
ostium.
See that ostium hasn't opened up well, yeah. Okay, down. Give the stent. Okay, good. Any other questions from the audience or from the panel?
So now in such cases, retrospect, we always think that planning, imaging, all these needs to be strategized in complex lesion. Because we started with a very complex lesion and we did imaging half the way. We straight away went to calcium modifying of the left main without studying the left circumflex. And so all the problems in sequence cascaded. I think strategization and planning is very important. The case has been done nicely and the patient is fine, safe, but situations can be where you can get into this situation and the patient may just start getting sick. So always.
What would you have done different?
So I would have first imaged both the vessels, planned whether I'm going with a single stent strategy,
Change the
whether I'm
stent.
coming, if I'm coming left
change
main
the
to
stent,
LAD, and if the circumflex was already suspicious, why not image the circumflex also and go either with a two stent strategy? We are seeing that the entire coronary arterial tree was calcified everywhere, left main. So if you are dealing with the left main where the calcium is, and you are going across the left main to LAD, you are likely to pinch the circumflex also.
Sorry, would you consider a short video NC to open up the struts a bit more maybe and try
We
to
did.
stent
I
again?
went at 275 at 20 atmospheres.
And after,
let us take a picture, right?
and the
You want
other
to put a
thing
shot?
is,
8?
use of cutting balloon. I don't know what is the opinion of the panel entire. In a heavily
What is this?
calcified lesion,
12
where does
stent.
cutting balloon
12?
stand?
12.
Cutting balloon is
Stent?
always for moderate
Which one?
calcification.
No, it's
So you
balloon.
some other calcium
Skank.
modifying tool like IVL rather than using a cutting balloon, putting 3 wires, using the old methods that my rota wire is also a blade, another wire is also a blade, and then a cutting balloon. I big disagree that this calcified lesion could have needed
8 millimeter stent.
with a burr. If we did with a 1.25, we could have gone up and made the calcium modification better because the left LAD ostial calcium has not opened properly. Here we have a circumflex heavy calcium. Now we are at the end struggling at every point.
Okay, let's go back and let's teach, please. Hold on. So here, this is how the wire was. You're telling me you would have gone 1.5 burr in this LAD? This is how the wire is, right? Number 1. Number 2, IVUS never made a turn at any time. Okay, it took us a long time to get IVUS down there. Then, after doing 1.25 burr, look at this.
So
there's already a wire bias.
Dr. Kinney, you could have broken that, that bend with a 2.25 or a 2.5 balloon and taken the IVUS catheter. You could have imaged it beforehand. And how can you do this, this moderate or severely calcified lesion
That's not what we teach people. That if you're already doing PTCA, then what's the point of doing atherectomy? Then you can go with IVL. Now, should we have just done LAD diagonal and left the circumflex alone? Yes, that should have been okay. 81-year-old guy. We could have done that. If we are struggling at every level with IVUS, getting into the left main to LAD, and you're telling me I have to do IVUS of the circ?
We are running out of time. Probably 1 more minute left. So we'll watch the circumflex getting stented.
We can do the IVUS of the LAD to left main. Good? Some die? Okay, go up there. Down. Go up here. Okay, down. Now here, right? Now go low pressure. So we really open it. Good. Let's take a picture now, and then let's post dilate the LAD. We are going to post dilate the LAD and do the final IVUS. Okay?
Do a kiss or no?
Okay.
Sure. Probably
Okay,
one
come, kiss.
angiographic and we can close from our end.
Yes, yes. Go up.
4, 6, 8.
We are going to do the kiss here. Go high. This one, yes. Okay, down. And let's do the IVUS of the. Now, yeah, the IVUS catheter would not go. Would a balloon would have gone? Might have gone. But that's not the teaching.
Is it on?
That if there is that angle and we know IVUS is not going, that if let us do PTCA and then consider atherectomy. You want to consider atherectomy at that time? Then yes, maybe you could have done IVL.
Yeah. All right. Okay.
Give me the IVL
Welcome to India and welcome to here in America from Mount Sinai Cath Lab with this marathon case. This is Dr. Sharma, and I've been hearing for last probably 45 minutes. Very tough case. I mean, clearly there are a lot of tough cases. There are always various choices, and you cannot have more expert performing these complex cases than Kini. The only thing I would say in nutshell while we are finishing it is that IVL could have been a little more upfront after little plaque modification at any level. High pressure balloon, cutting balloon or rota, but more importantly, use IVL more liberally. That's it. So that will be my point in this, yeah.
Interesting. Okay, expansion. Coming to the proximal.
How many people are still remain in the audience? I know it's already 8:30 there, right?
Everybody is here.
Everybody is here, okay.
Now,
That's good. We always like to struggle.
Nice.
People love to see struggle. You know, many times they say in our CC symposium, you know, we didn't learn much because operator didn't struggle. But point is at every point, a lot of discussion, lot of choices were shown.
Looking good?
Yeah, LAD left main stent perfect.
But
Very
remember the imaging, I know a lot of IVUS, but IVUS never crossed in the beginning. Just one second, what I'm making the point. That IVUS, biggest one trouble was IVUS did not cross. But so we knew exactly in the series, you don't need to be rocket scientist that this was a severely calcific lesion. And IVUS would have told just that. But anyway, now you see this is the end result. There is little ST changes in the probably from the diagonal in my opinion. Let's see it now. And I think good, nice vasodilator. Let's bathe patient in sodium nitroprusside and verapamil. So they vasodilate everywhere before taking any picture. But EKG wise, you are seeing the EKG, little ST depression in lead 3.
Just from that diag probably.
Yeah.
But
so one thing for sure, yeah, and also I agree that wiring the diagonal before stenting should have been done. So that I'm a big proponent of that. Although remember that overall trial showed keeping the diagonal does not prevent occlusion, but it prevents the restoration once the vessel occludes. The meta-analysis trials of the showed. But here we are now. The diagonal, I don't know which diagonal we are talking about.
The diagonal is this one. The question is the same thing. We are struggling. Every vessel that we thought we want to intervene,
play the diagonal.
Right? We were struggling.
Oh,
so that is where it was.
Yeah, that's all right. So, okay, everything looking good, and I think it has been, you know, like long case with every aspect. Go to the last picture. And I think it's a time to, we'll do the ECG. And what we do in this case, if there are significant EKG changes or chest pain minus, that we'll put a balloon pump. And what we have shown that by putting a balloon pump, enzyme release is less. I mean, nobody has a stent thrombosis, but its key is that the enzyme release, chest pain, hemodynamically remained good. Right now, pressure is on the borderline, but that is all because of the nitrite given to this patient. We can wait a little bit, right?
Ready?
One more second, yeah. Okay, let's take the last picture then. All right, look at this. I think overall this require a big clap, my friend.
Yeah, there is a big applause in the crowd
yes,
here.
Yes.
Thank you, Dr. Kinney and Dr. Sharma. We had an excellent case demonstration and very well, debated over all the trouble points.
Yep.
Thank you very much, Dr.
That's our cath lab staff can come here. Everybody can come and say hi to
No, we did in the
India Live.
beginning.
Okay, now in the end also that everybody remained there and we remained there here all. And the joined both, it was a relay team. Thank you.
Thank you very much
Bye-bye.
for the
Thank
great
you.
case.